Everyone. Thank you so much for participating in this academic activity. We are going to have bladder cancer discussion in continuation of our academic activities under the aegis of Indian School of Urology. With this, I would invite our President ISU, Arun Chawla sir, for opening remarks. Arun sir?
Arun sir, you have to unmute yourself. Arun sir, please unmute.
Yeah, greetings on behalf of Indian School of Urology, USI. At the same time, warm welcome to all of you who have joined for today's webinar on bladder cancer. I believe that the program scripted today by our trio of Dr. Ashwin, Ravi Mohan, and Gopal will cover all the important areas in bladder cancer. And it is well scripted to cover all these important issues in the form of debates, the case discussion, and keynote lecture, and as well as the expert comments. At the same time, let me thank the faculty from the USA as well as our international faculty, Dr. Ashish Kamath, for joining for today's webinar on bladder cancer. I'm very confident that that everybody who is doing this webinar will be really benefited. With this, I hand over to Ashwin. I think I'm really excited to see all the key faculty of USI who are uro-oncologists and expert in the area of uro-oncology here, joined as an expert or as a part of panelists and faculty. I won't stand too long between the webinar and you all. Over to you, Ashwin.
Thank you, sir. I would request for quick opening comments from Lakshman Prabhu sir, our Honorary Secretary, Urological Society of India.
Thank you, Dr. Ashwin. Good morning, Dr. Kamath. Lakshman here from Mangalore, and I bring warm greetings from the Council of USI, and would make a quick comment that it appears to me, and I think it is a well-known fact, that bladder cancers are the most expensive cancers. They run a long drawn-out course, and if it is an out-of-pocket expenditure, it can be quite heavy on the patient folks. And any amount of nuanced knowledge is not enough. And this should not only be with the uro-oncologists, the hardcore uro-oncologists, but also should percolate down to general urologists so that they can also make proper decisions, proper referrals, and participate in shared care. With this, I am looking forward to a very good package on bladder cancer, and also looking forward to listening to Dr. Kamath on the nuances of risk stratification. At the end of the day, I think it's the nuanced clinical thought. It is the clinician and the caring doctor which makes all the difference for the patient. Thank you very much. I wish this webinar all the best, and also welcome all those who are logged in. Thank you very much, Ashwin. Over to you.
Thank you, sir.
Get started.
Yes, sir. So it's a pleasure to introduce our chairpersons, Dr. Makarand Kochikar sir and Dr. Anish Srivastava sir. Thank you so much, sir, for being here. And let's start with the academic activity, and then in the end, we will have the expert comments and words of wisdom coming from the chairpersons on all the topics discussed. We are fortunate to have Dr. Kamath participating from US. He had a very busy schedule, and it's a fortune for us that he is with us today. So with this, without any further ado, we'll start with the academic session. We are going to have an opening debate. The topic is restaging TURBT. Dr. Amitav, you can start sharing the screen. So restaging TURBT necessary for unifocal T1 high grade 3 centimeter lesion after an initial complete TURBT in 2023, assuming all possible avenues are available. That's a little longish title, but I just wanted to cover all the possibilities. Thank you so much. Over to you. Dr. Amitav is going to say yes for it, and Dr. Mahendra Pal will be debating in favor of no.
So can you hear me, and can you see my presentation?
Please. Yes, please.
Yeah. So good evening to everyone. So greetings from Rajiv Gandhi Cancer Institute, and thanks for this opportunity to speak in favor of TURBT in a single site, single lesion, T1 high grade 3 centimeter lesion after complete TURBT in 2023 with all possible available avenues, be it MRI, enhanced endoscopy, or in block and resection. So organizer made it very difficult for me to defend the role of TURBT in this particular clinical setting, but I still believe there is a role of TURBT in this setting, and I'll tell you why. So considering the characteristic of the disease, this disease becomes a high risk according to EAU guideline and AUA guideline. So there are issues of improper sampling with the first TURBT in all high-risk disease, be it a TA high grade or T1 high grade. So it has been seen that there could be a residual disease in 30 to 50% of the patient. And this residual disease could be a leading cause for the recurrence at the same site in 20 to 30% of the patient. Or in all over the bladder, the recurrence rate could go up to the 50% of the patient. We can get upstaging in up to 20 to 50% of the cases, and that could lead to the progression in 20% of the cases. So this is the study from Har et al. From MSKC Institute. So they reported that there could be a residual disease up to 80% in T1 disease if there was no detrusor muscle present in TURBT specimen. Apart from that, the residual disease incidence could be as high as 65% even in TA high-grade disease. And the re-TURBT significantly lowers the recurrence rate and progression rate also. So we can criticize this study for being a retrospective nature, single-center study, and very high incidence of residual disease, which are not usually seen in real-world scenario, but things are not different in other part of world also. So according to this prospective randomized trial from the Turkey, overall, there was almost 33.3% residual disease after first TURBT. And if patient had high-grade disease at the first TURBT, there could be residual disease in 42.8% of the cases. Whereas there could be upstaging also in 12.5% of the cases. On multivariate analysis, it has been seen that presence of high-grade tumor more than number 1 lesion, the size more than 3 centimeter independently is prognostic for presence of high incidence of residual disease after first TURBT. And same as her study, it has been seen in this study also, the rate TURBT significantly increases the recurrence-free survival and progression-free survival, which keeps on continuing even in extended follow-up of all these patients up to 10 years. Next important issue is upstaging, which can be seen in up to 20 to 30% of the patient. The risk of being understaged was lowered by 16% for each additional TURBT performed. And if patient is properly staged after re-TURBT, then they have a significantly higher 5-year overall survival outcome compared to those patients who are understaged and those who did not undergo re-TURBT. Re-TURBT again helps in better characterization of the disease associated aggressive factors, because it has been seen that after first TURBT, there is not a good concordance between the final histopathology of TURBT and radical cystoprostectomy. It varies roughly around 70%, which can go up after re-TURBT and which helps in better characterization of the disease. Apart from that, after doing re-TURBT, after having extensive sampling of the lamina propria, we may better characterize the T1 disease, whether it is a microinvasive disease at the lamina propria or whether it is having extensive infiltration in the lamina propria. Because those patients who are having extensive lamina propria invasion, they do much worse in their follow-up and they are ideal candidate for the early cystectomy. So altogether, after removal of the residual disease and after better characterization of the disease, probably after doing this re-TURBT, we can provide a better response to the adjuvant therapy, just as in Nimbus trial we have seen with the BCG. So just remember these two outcomes, that in Nimbus trial, we had 1-year recurrence-free survival of around 90% and 2-year recurrence-free survival of around 85%. The reason for this good outcome, which is much better than their contemporary series, was because most of all these patients, approximately more than 90% of the patient in both arms underwent re-TURBT. And things are not different in Indian studies as well. Therefore, in all international guidelines, there is a strong recommendation for re-TURBT in all high-risk disease, be it EAU, AUA, NCCN guideline, NICE guideline, or ICUD guideline. So the next important question is, can the use of MP-MRI before radical re-TURBT helps us in vomiting, skipping the re-TURBT? Then answer is no, because despite of having good sensitivity and specificity of Vireit's score more than or equal to 3, there is still significant rate of persistence of non-muscle invasive bladder cancer detected in re-TURBT up to the tune of 31.5%. So now I would ask you to presume this scenario. So this patient underwent, suppose, MP-MRI in pre-op setting and was categorized in either muscle invasive bladder cancer or non-muscle invasive bladder cancer, depending on their VIRADS score. And if suppose probable patient who had muscle invasive bladder cancer, depending on the VIRAD, underwent TURBT, and on final histopathology examination, it turned out to be non-muscle invasive bladder cancer, then still this patient would require TURBT to rule out any false down staging. Another scenario is if on MRI, there is a possibility of non-muscle invasive bladder cancer, and still after TURBT, his final histopathology in non-muscle invasive bladder cancer, then still this patient would require TURBT to rule out any residual disease. Hence, I don't see any extra advantage of doing MP-MRI in these patients preoperatively. Beforehand, this MP-MRI can also not predict presence of carcinoma in situ, variant histopathology, lymphovascular invasion, because to predict these factors, we need to have a pathology specimen. That's why we cannot omit TURBT in this patient. And doing MP-MRI after TURBT is not a good choice because of the tissue artifact. And we all know, because it is not a real-time imaging, so you cannot tell during TURBT that you are leaving the residual disease depending on the pre-op imaging or pre-op MP-MRI. Therefore, we need enhanced imaging, that means PDD or blue light cystoscopy, because it has been seen that PDD increases the detection rate of papillary tumor and flat carcinoma in situ up to 30%. It also reduces the rate of residual tumor after TURBT compared to the white light cystoscopy up to the tune of 20%, and hence it increases the recurrence-free survival and it prolongs the recurrence-free survival intervals compared to white light cystoscopy, but there is no significant difference in terms of progression-free survival. Therefore, all the international guidelines recommend use of PDD if it is available at your institute. But it is the only truth we should believe? No. Because from the CISView registry group, Mohamed et al. Tried to evaluate the comparative study between the blue light cystoscopy and white light cystoscopy. And they did not find any significant difference in terms of residual tumor when blue light cystoscopy and white light cystoscopy was used for initial TURBT. So on repeat TURBT, there was TA also, there was T1 also, there was carcinoma in situ also, despite of using PDD at the first TURBT setting. Again, there was no difference in terms of upstaging to muscle invasive bladder cancer also. Next trial, randomized trial, which was photo RCT, it again evaluated blue light cystoscopy compared to white light cystoscopy, and it again didn't show any significant difference in terms of recurrence-free survival at the follow-up of 3 months. But definitely, there is learning curve which is associated with blue light cystoscopy. So you need to do more than 40 cases to optimize your recurrence rate, whereas in white light cystoscopy, you just need to do 10 cases to optimize your recurrence rate. So there is a lot of enthusiasm in terms of in-block resection, because it has been proposed that histological assessment would be much better with in-block resection, and remaining in the same surgical planes may decrease the complication. Again, avoiding tumor fragments may decrease the tumor displays, hence it will improve the recurrence rate and oncological outcome of the patient. But there is a different story in the hybrid blue actually, which was a randomized trial and multi-center trial in the Germany. Although detrusor adequately was accessible in block resection compared to the TURBT, significantly much better, but there was no significant difference in terms of detrusor muscle presence in both group. And resection time was significantly higher in block group. And if you'll see the 12-month recurrence in block resection group, it was 40% compared to the 23% in TURBT arm, and progression was still higher in block resection. So here I would say you just remember the outcome of Nimbus trial. So at the end of 1 year, there was only 10 recurrences because all these patients, they had re-TURBT after the TURBT. Another trial which was randomized, non-inferiority trial, was published in 2022. So here they tried to include the patient who had less than 3 centimeter tumor, 3 or fewer lesions with no sign of muscle invasion, and it was a non-inferiority trial. So 300 patients were recruited, but ultimately 248 patients were taken for the analysis. And what they found that although T1 substaging was significantly better in block resection, but there was no significant difference in terms of detrusor muscle presence in both groups. No significant difference in terms of complication rate of postoperative adjuvant treatment, catheterization time, hospital stay. And the recurrence rate in this group at the end of 15 months was 18%, whereas it was 13% in block resection group. So they were clinically insignificant. But I would like to remember you. So this is last. So at the end of 1 year recurrence, so in the Nimbus trial, there were only 10% recurrences because all these patients, they underwent re-TURBT. So in summary, it is premature to say that there is no need of re-TURBT with all available avenues. Still, this patient needs re-TURBT because there are real concerns about the upstaging, recurrence, progression of the disease. Re-TURBT facilitates response to intravesical therapy, and it is predictive of outcome. Thank you.
Thank you so much. Let's listen to the opposite view from Dr. Mahendra Pal, Professor of Uro-Oncology, Tata Memorial Hospital. So please start sharing the screen. Yeah, it's visible, sir. Please go ahead.
Okay. Am I audible?
Yes, please, sir.
Yeah. So my topic is to say against no but rarest TURBT. So as we know, what is the definition of complete TURBT? It is there's a no visible lesion under the endoscopic examination or no gross tumor in the pathology. The best can be seen by the cystectomy, but it is not practical for the NMIBC. So for the complete TURBT, what a definition is, the resection should be done in the total entirety or the piecemeal to remove the bladder, including the bladder muscle. And the presence of detrusor muscle in the specimen is considered a surrogate marker for the resection quality. And the resection specimen must helpful to differentiate between the NMIBC and the MIBC. So for the background, as Dr. Amitabh already mentioned, that there is a residual disease. And if you see all the lines, the one thing is common is present and absence of detrusor muscle. And also, most of the residual lesion were detected in the where the first tumor was resected. So here one article by the Browsey, they questioned that why should we deliberately resect a patient with NMIBC twice? If we do so, do we admit that we perform an incomplete, insufficient, wrong operation or an inadequate TUR? And the proposed reason, as per their paper, was too little or no more time dedicated to TURBT. And urologists do not think enough about the consequences of incomplete or inadequate TURBT. And most of us consider TURBT is a small or easy operation, and it is the most common uro-oncological procedure to start for the anti-residency program. And they concluded that after all these data, they concluded that research TURBT should be performed only when the muscles is not present in the specimen. Surgeon pathologists are not sure about the procedure and the diagnosis. Patient referred by the lower volume institute, and bladder strategy is a plan for the patient. Another study, prospective study with the 356 patients, they included the surgeon experience as a variable along with tumor size, multiplicity, grade and stage of tumor. And the 5-year was the cutoff time for the experienced and unexperienced surgeon. And detrusor muscle are present in the 67% of the patient. And they found that detrusor muscle in the specimen are present in 50% of the patient by the junior and 70% by the senior. And they concluded that detrusor muscle absence and presence in the first TURBT may be a surrogate marker, and it independently, depending on the recurrence-free survival, but it dependent on the surgeon's experience. Other paper from the SGPGI prospective study aimed to assess the tumor detection and the staging of migration, and they see that the solid tumor has a more residual and the residual rate compared to the papillary tumor on the restage TURBT, as we can see. And again, recurrence rate when the TURBT was performed or not performed was more when the restage TURBT was not performed. Along with that, they also see one other aspect that is important is the logistics for the patient about the to go the restage TURBT, the logistic, the cost of repeat surgery, and the complication with the TURBT. Restage TURBT may not be performed in the correct time, like 2 to 6 weeks, because of lack of availability of the OT, and the patient is not ready financially. A poor compliance of the patient, and the symptom resolves. Some patient reluctant to undergo surgery. Why to go surgery when my symptoms are gone? And generally this happens in the tertiary care setup of India. And by this they concluded restage TURBT necessary in patient with solid bladder tumor. The presence of tumor at the restage confirms high risk of the recurrence and the progression, and poor patient compliance for the restage TURBT remains a matter of concern. Another article, the always needed for restage TURBT. Restage TURBT carried out in the patient if muscle was not present in the primary TURBT specimen. Hence, this study questioned the role of restage TURBT with a completely resected high-grade T1BC. It does not translate into better oncological outcome. And given an impact for both the patient, the need of TURBT is completely resected high-grade tumor should be further investigation and framework for the randomized control trial. Unfortunately, that has not been done yet. The recent article published in 23, they see the long-term and short-term recurrence rate after the RBT, and they concluded that long-term recurrence rate was there's no difference between whether the Restaging TURBT was done or not done. This abstract was shown in 2023 in AUA, where they compare the multicentric study. They compare the tumor grade and other parameters around the dorsal muscle, and they found that after controlling the tumor size, number, stage, and grade, there was significant residual variation attributed to the site, not for the tumor stage and the grade. And they concluded that there's a significant variation in the early recurrence rate between the site, but that could not be explained by currently understood tumor features such as size, numbers, stage, and the grade, and differences in surgical techniques and perioperative practice that may impact this and may need further investigations. Now coming to a role of MRI, as Amitabh said very well, MRI can only differentiate between the MIBC and the NMIBC. It cannot differentiate the real residual tumor, the role of TURBT. But if we see the sensitivity of the MRI in detecting the MIBC is approximately up to 85% and 96%. And within the high-risk NMI-based case, Y-rate could in future may replace the Restaging TURBT, but we have to wait for the more strong studies. This abstract was shown in this year, last year, maybe for last year, and it showed the real world staging. MRI showed high performance ruling out MIBC, and also in the residual disease, MRI may be helpful, be promising investigation in the future. Coming to enhanced cystoscopy during the TURBT, as we all know, there are many things still available. Most common are the blue light and the narrowband imaging. This review article shows that, including 16 RCT, and shows that all favor about the blue light cystoscopy, and they concluded that there is a favorable impact of blue light cystoscopy TURBT for risk of disease recurrence and the progression. And when we complete, again, there is one abstract presented this year, and it says that TURBT using blue light cystoscopy and HL does not reduce rate of residual disease or risk of staging. Hence, Restaging TURBT has to be performed even after the HL. So HL, again, it is not a 100% proof that the tumor will not recur or the residual disease. Now coming to narrowband imaging, this systemic review and meta-analysis shows there is no difference in recurrence rate of narrowband imaging. However, there is a trend in favor of its use during the TURBT.
So 1 minute to conclude.
Yeah. So one other an NBI compared the NBI and dynamic therapy, and it concluded that both the modality are better than the white light cystoscopy in reducing recurrence and the progression of disease. Now coming to en bloc technique. En bloc technique by the paper, the SGPGI, it shows there is a more diaphragm retrieval rate compared to conventional in the en bloc resection, and adequacy of the initial TURBT is equal in en bloc compared to the conventional TURBT. And again, surgical margins in the horizontal edges were free of tumor in all patients who underwent en bloc TURBT. So en bloc TURBT is comparable with the conventional TURBT in all the aspects, including the margin and as well as the muscle retrieval. Our experience, we compare our TURBT cases in our cases who did the low volume center, maybe outside from the TMH. And we found that there was a 54% of the patient did not have dorsal muscle in the specimen compared to our patient, and during these tests TURBT, we found 22% of the patient having residual disease compared to 0 in our patient. And we conclude that surgeon's experience, volume of cases, and surgeon confidence are the important factor in achieving complete resection of the tumor in the first stage. As the guideline recommend the same thing, if you see the last line, the recording of the result of second resection reflect the quality of initial TURBT. That means initial TURBT are the most important factor to prevent the recurrence in the same site. Even the guideline proposed the same thing. So I want to make a conclusion of the statement that Restaging TURBT is an integral part of managing of NMIBC, especially high risk, number, T1 or high grade. Apart from that, presence of dorsal muscle in the specimen is a determining factor of completion of the resection that is skill dependent. MRI enhanced cystoscopy may or are promising tool to achieving complete resection during the first TURBT. Introspection is equivocal to conventional TURBT. All high-risk NMIBC does not warrant Restaging TURBT, but incomplete one, yes, they deserve Restaging TURBT. Non-oncological aspect, as we discussed, must be also be considered while planning the restaging TURBT. So we should choose wisely. Thank you.
Thank you so much, sir. With this, we would like to invite Dr. Ashish Kamath, sir, for his expert views on this particular debate and the perspectives.
Thank you very much. And again, thank you for inviting me to be part of this very important meeting. Both sides were covered really well. And one of the things that I want to highlight is something that was brought up earlier. The TURBT is one of the most underappreciated but most important parts of the procedure that occurs during the care of patients with bladder cancer. In fact, if you actually look and see, more patients die from inadequate TURBT than from inadequate radical cystectomy, because the way a TURBT is done affects everything about the patient: the staging, the subsequent recurrence rates, the need for chemotherapy, variant histology, et cetera, et cetera. And when you factor that in, there's no surprise that this debate is something, I organize the bladder cancer sessions for the AUA and the EAU every year for the past, 10 plus years. And every year there is a request to include this very question in a debate. And the reason for that is very simple. It's very nuanced. So all the studies that were presented, published, et cetera, try to look at a broad question and answer it across the board. It's not that easy, right? Because if you have a patient that has a T1B lesion, where the T1 is widely invasive in the lamina propria, even in the best of hands, the most experienced hands, there is a significant incidence of understaging these patients. On the other hand, if it's a T1 with a small focus, just a micro focus of tumor, chances are, if you're a very good resectionist, you've already got muscle present, you don't need to go and do a re-resection. And MRI, en bloc, et cetera, they just help us. And the results today are better than they were maybe 10, 15 years ago because of high definition monitors, because we have blue light, narrowband imaging, MRI, et cetera. But it doesn't take away the fact that unless the patient is lucky and you are an exceptional resectionist, the chance of understaging is at least 10%. And that means you have a 10% chance that you're going to treat someone with muscle invasive disease with intravesical therapy. And muscle invasive disease can kill patients. So that's why currently on all the board exams, if someone's sitting for the AUA board, the EAA board, the London board, the right answer is yes, T1 high-grade disease does require a repeat resection. In the real world, if an expert uro-oncologist has done the resection, it's T1A, you've used white light, you're very sure that the narrowband imaging and blue light also did not show anything else, could you skip the re-resection? Yes, but that's not the general right answer. So I'll leave it at that.
Absolutely. Thank you so much, sir. So in India, we get common situation of TA high grade, though we understand it's hypothetical scenario. It depends upon the expertise of the pathologist as well. But does it actually stand true? And if it is a TA high grade, can we skip the TURBT as well, re-TURBT as well?
No, so TA high grade is actually one of the most common non-muscle invasive bladder cancers that you will detect, right? So if you look at the distribution of bladder cancers, TA is the commonest stage. So it's not hypothetical to get a TA high grade lesion. And again, on the AUA board, the recommendation is anyone with high grade disease, consider a repeat resection. But with TA high-grade disease, if you have visually resected the entire tumor and your pathologist tells you that there's lamina propria present in your specimen, doesn't have to be muscle, but if there's lamina propria present in your specimen, then you can skip a repeat resection, because there, with the current modalities that we have in expert hands with high definition monitors, the impact of a TA high-grade re-resection is minimal. Now, of course, we've looked at this in our series, and if you look at it across the board, there's still a benefit, but it's small enough that you can skip that in the patient, because all you're missing is a recurrence, not progression to metastatic disease or muscle invasive disease. On the other hand, in T1 high-grade disease, you're not only missing a potential recurrence, but you're potentially missing progression to metastatic disease, which clearly, as we know, is a killer, and there's no cure for metastatic disease.
Thank you so much, sir. So with this, for the want of time, we'll move on to the second debate. It's the dilemma in one of the, as a young urologist or uro-oncologist, it's a dilemma in my mind that in my career, whether we'll be skipping the cystectomies after complete response to systemic therapy. So that's a sentinel question. The pro is going to be defended by Dr. T.P. Sahu, who is a medical oncologist from Bhopal. So over to you. Please start sharing the screen. Dr. Sahu?
Yeah.
Yes, please.
It's not 1 minute.
Ashwin, quick question for you. I'm seeing questions pop up in my chat.
Yes, please.
You want me to respond, or will you ask me?
Yeah, if you can go ahead with any of the questions in the meantime, sir.
Till the time. So let me address the first one of the T1 with plasmacytoid differentiation. Plasmacytoid bladder cancer is extremely rare, extremely dangerous. Less than 1% of bladder cancer patients come up with plasmacytoid. So I would recommend that you have an expert pathologist re-review that. And if it's plasmacytoid, that patient needs a radical cystectomy, no re-TUR, nothing. Even with TA disease, if you do a radical cystectomy, even with a radical cystectomy, 50% of these patients will not be alive in 2 years. If you don't do a radical cystectomy, the survival rate with metastatic disease is 0. So nobody will survive. So that's that. And then the second one, TA low-grade disease, extremely rare. Again, barely 1 or 2% of the bladder cancer patients will have T1 low-grade disease. So make sure your pathologist has looked at it. More likely it's a nested variant where you have pushing borders, and it's not a true T1. It just looks like it's T1 because of the way the section was taken.
Absolutely. Dr. Sahu, are we ready with the PPT?
Can you, I've shared one, I'm not able to open it. Can you do that?
No problem. So Kiran has it. Kiran, can you open it? I've shared the same PPT, and maybe what we will do is we'll go with the next speaker and then come back to you. So
yeah.
Kiran, would that take much time to open the PPT for Dr. Sahu?
I'll just look into it, sir. 1 second.
Yeah. Or else I can just ask Dr. Srivatsa to start defending it. Srivatsa sir, do you want to go with that never ever strategy for cystectomy? Dr. Srivatsa? Yeah. So, sir, it's a pleasure to invite Dr. Srivatsa. Sir is a senior uro-oncologist from Sri Shankara Hospital, Bangalore, and he's going to say no for the premise of having no cystectomy for we are going to continue cystectomy. Basically, it's a surgeon's view. Please go ahead, sir.
A very good evening to all, and many thanks for the opportunity. Never ever might be an outrageous statement even for a surgeon. So I wish at some point in time we actually get to preserve bladders, because bladder cancer is a very complex disease. It does not uniformly respond to the standard lines of treatment that we have today. It is complicated more and more because of the presence of variant histology, which we are trying to understand is more and more common, with the new series coming up with presence of variant histology in as high as up to 40% of the patients. The other thing about complexity of bladder cancer is the presence of carcinoma in situ in more than 1/3 of muscle invasive bladder cancers, which typically are, tend to be more aggressive than when the disease is not, the carcinoma in situ is not there. And like the previous speakers mentioned, we do not have good strategies to stage locally the disease, especially in assessment of treatment response. We know historically that the neoadjuvant chemotherapy helps increase the overall survival in patients with muscle invasive bladder cancers. But based on the Advanced Bladder Cancer Consortium data, only 54% of patients are actually eligible to take neoadjuvant chemotherapy for various reasons like multiple comorbidities, old age, altered renal parameters, so on and so forth. And the SWOG recommendation of MVAC, which made neoadjuvant chemotherapy prove beneficial in these subsets, are significantly underutilized because of extreme toxicity rates. And in spite of all these, the historical responses, pathological complete response rates with neoadjuvant chemotherapy has been low, that is up to 35% at best in various series. I quote only complete pathological response because that is the only scenario in which we tend to avoid doing a definitive local treatment. Immunotherapy has taken off late and probably doing well as well. These are the responses to neoadjuvant immunotherapy. These are all, mind you, these are all short-term responses because we haven't used immunotherapy for a reasonably long period of time. It can be as best as about 46 to 49% with different drugs or drug combinations. Now coming to the challenges of not doing a local treatment. Carcinoma in situ, like I mentioned before, can be very aggressive, can alter the way the patients respond to treatments. There are several trials which have looked at carcinoma in situ and cancer-related outcomes. There are 2 trials worthy of note. One by Professor Nikhil Wasde, which said that there is no effect of CIS in reference to neoadjuvant chemotherapy. However, the larger trial by Parker et al. Showed that, when CIS was present, there was a decreased complete response rate on radical cystectomy specimens post neoadjuvant chemotherapy. Similarly, the other bone of contention is patients with variant subtypes of bladder cancer or the variant histology as we know it. Pathological complete response rates are very poor and are remarkable only in certain variants of variant histologies like the small cell or the neuroendocrine variants. And it is also now noted that immunotherapy probably works better after a priming with chemotherapy, thereby making immunotherapy as an ineligible neoadjuvant option in this subset of patients. If you look at the chart here, the confirmed objective response rate after immunotherapy was roughly 22.2%, whereas after radical cystectomy, it was considerably low, that is only 11.1%, and it was even further lower when chemotherapy was used in the variant histology setting. The other concern is the durability of response without any local therapy after neoadjuvant chemotherapy. Several studies have looked into it, and the overall summary is that close to about 55% of patients do have recurrence rates when they subsequently undergo radical cystectomy after a documented clinical complete response. Not only that, we also do not understand the differences in the recurrence pattern after the neoadjuvant treatments that we offer. And there are very few articles. This is one article which showed that the neoadjuvant systemic therapy could only lesser the loco-regional recurrence rates, but the systemic failures were consistently high. However, multiple drugs and drug combinations were used in this setting, so we are not sure as yet. This is more important, the real-world data on responses to neoadjuvant therapy. There's a very beautifully written article. It's a multi-center real-world retrospective study published in 2022, looked at 17 centers and a reasonable number of bladder cancer patients. And what it showed was that complete response with chemotherapy alone in the real-world setting was only 11.2%, whereas it was documented to be close to about 40% in the trial settings, and with immunotherapy was 14.6%. These numbers started reducing further when variant histology was present, and this actually makes us, really introspect if the real-world data can actually match what was seen in the trial outcomes. This is probably more important, the fallacies of, the clinical response, because as on date, the clinical complete response is the only valid surrogate marker to assess pathological complete response, and that is done using cross-sectional imaging, cytology, and re-TURBT. And there are several trials which have shown that close to 48 to 50% of patients actually had residual disease even when they were marked clinically complete responders. This included even a SWOG study, which was a phase 2 trial, which demonstrated an unacceptably high rate of persistent cancer when patients subsequently underwent RC, having documented T0 status. Even when TURBT was done, and it was apparently documented that there was no residual disease on the re-TURBT specimen, what was noted is that when subsequently patient had to undergo a radical cystectomy, this was a trial which did a re-TURBT and followed it up with a radical cystectomy, and what they showed was that 47% of patients had clinically significant residual disease even after a documented clinical complete response on TURBT, amongst which almost half of them, that is 23% of them, had T2 disease or more, even when it was a documented RT. So 1 minute. Last two slides. What we don't know is that we do not have any prospective data. There is no RCT done in this setting. We do not understand the long-term durability of response, immunotherapy especially, because it's been there only for last few years. We do not understand the long-term consequences of systemic therapies, whereas radical cystectomy complications are well established. The challenges of salvage options, God forbid if the disease were to recur, is not known. How to treat these patients in the event of recurrence, do not know. And to conclude, there is a significant limitation in understanding the pathology and aggressiveness of response to therapies, especially in the CIS and variant subtypes. There is an unacceptable discordance between the clinical versus pathological response rates. Long-term outcomes are not known, salvage treatment options are not clear, and bladder preservation in MIBC as I personally feel is highly desirable. We are not there yet. And I conclude by saying that radical cystectomy after any form of neoadjuvant systemic therapy, despite apparent T0 outcomes, will continue to remain the standard of care. Thank you very much.
Thank you so much, sir. Wonderfully as in defended the topic of pro-cystectomy. So, Dr. Sahu, sir, can you stop sharing?
I'll just do that.
Try once, otherwise she is ready. Yeah, I think we can see your slides. Please go ahead, sir.
Yeah, 1 minute. Okay. Am I doing or she's doing? No, she's doing it. Okay, next slide, please. Basically, the topic that was given to me was, after we achieve a response, clinical complete response, do we just can avoid it? And it was probably maybe, next one, please. And what next? And for me, it will be yes, and it is okay not to do a radical cystectomy after you have achieved a complete response. Next, please. So I will just tell you a tale of two cities. All of you have heard of it, Charles Dickens, and beautiful book. Next. So what I next will look into is the tale of two cancers, and look further. Go ahead. So we have rectal cancer. Next, please. And where we used to do colostomy in most of the tumors. And this came the drug last year, which came into the dostarlimab, and we had complete responses in CRs of approximately 100%. And that trial has been extended further to around 35 patients, and all of them are in CR. So here in rectal cancer, now not operating has become a reality. Next. With the advent, next please. With the advent of the total neoadjuvant treatment in rectal cancers, again, not operating is now a reality, and most of our patients are also being offered when they achieve a response, although not still a clear-cut strategy. Next. Next, yeah. So is it that we are moving to that even in cancer gallbladder? Next. So should we even consider the option of no cystectomy is my topic in this select group of patients. I'll defend the topic by some evidence. Next, please. So if you look at it, that is well spoken. I'll not allude further that beyond T2 and beyond, neoadjuvant therapy is the standard of care. And once you do a neoadjuvant chemotherapy or any sort of therapy, you are expected to achieve a complete response in around 30, 35, 40% of cases. And in those who you achieve that, can you probably take away and not do cystectomy? Next. So this is the SWOG trial. And if you look at it, this is the trial which really defined that neoadjuvant chemotherapy is the way to go ahead. And it was better to cystectomy alone. Next, please. Next. And if you look at this subset, the upper two graphs, which was looking at those who achieved a complete response, and look at the 5-year survival. This will be my standout landmark. Around 80% of the patients who achieved a complete response would be surviving at around 5 years. So can we do that without cystectomy is the question that I want to look at as an oncologist. Next. So coming to the first retrospective data of 71 patients from Japan. And if you look at it, they had the patient refused cystectomy after maximal TURBT plus neoadjuvant chemotherapy. They restaged, and once the patient had the CT0 in situ or a T1, they could undergo a second TURBT after 4 to 6 weeks. And if still there was no residual lesions, they continued with observing the patient. Next. To cut the long story short, next. If you look at the line marks of the 60 months, that's the 5 years data, and you look at the survival probability, it's around 80% what you saw in the SWOG data. And this is without cystectomy. Next. And look at the covariables. If they received neoadjuvant chemotherapy and they had a non-invasive downstaging, that were the patients who did well and could survive a 5 years overall survival of around 80%. Next. So now let's come to a MSKCC prospective data of around 63 patients who again refused cystectomy. Go ahead, please. And if you go to the next one and look at the covariables, those who had achieved the CR, those were small tumor sizes initial to bring with a single tumor, or if you look at these covariables, and this was found on a multivariate analysis to be significant of survival, which was equally good without cystectomy. Even next slide, please. And look at the overall survival for all the patients, irrespective of they achieved a CR or not. It was 64% at around 5 years. Next slide, please. And look at the survival difference of those who achieved a CR versus who did not. And that is very, very significant. And that tells you a story that probably we do need a randomized trial now, and these patients could probably get away without a cystectomy. Next. So again, we go to a data from US. Again, the 14850 patient data. Next, please. Again, the same story repeats if you look into that. The patients who did not and refused a cystectomy and those who were in CR, these patients had, next please, had a survival at 5 years beyond 70 to 80%. Next, please. Yeah, and this is not the only data. If you look at it, this slide was shown by my colleague, and this shows a very uniform survival, except for one trial at 5 years of beyond 80 to 85%. And that is without cystectomy. Next. So looking at immunotherapy, do we have a larger set of trials, longer follow-up? No. Next, please. But look at the data. We have data mainly from the pembrolizumab and the atezo, although all the other two data which are shown is there. But look at the CR rate, and it is approximately 35 to 40%. The 1 year OS is around 90-91%. So this is the data that's evolving even after immunotherapy for patients who are platinum ineligible. And that is what it is. Next. So now, who would refuse? I think when you speak to a patient, and if the data is shown in a nice way discussed, I think the patients would consider this. But yes, there is no level 1 evidence. That's the takeaway, and all of us know that. Patients, elderly age, in the American study, the African American race, advanced T stage, and are those who probably would be very, very reluctant to undergo a cystectomy. Next. So one thing is consistent from the data which is there. The 5-year survival in those patients who did not undergo cystectomy but achieved a CR was around and more than 60 to 80% across trials. The 5-year cystectomy-free survival was also similar. Next. So one thing I want to say before I move to toxicity, the last 2 minutes. The ICMR data is very, very clear. It is up for last few months. They are even advocating the no cystectomy for unfit patients, and even patient refuses. These are two subset of patients which ICMR guidelines have put forward in their document. So now, what are the drawbacks if I do a cystectomy? Next, please. These are the complication rates which you would normally see, and you all as urologists, onco-urologists are well aware of the same. Next, I'll go to something more pertinent. The top one is the adverse events which a patient faces within the early period of 30 days. The lower one is within 90 days, and look at it after the cystectomy, which is on the lighter grayish graph, the bar. It's around 60% of patients in the short term, 45% of patients in the midterm. Next slide, please. And approximately 70% of patients have some sort of complication. And that is the data which you have to think about when you have a patient with a CR, and can we just offer it and not be adamant about cystectomy? Next.
Okay. 1 minute to conclude.
Yeah, I'm completing. So now also look at the cost, and this is from the American data set, and looking at a 5-year set, even the long-term period, if I convert into Indian rupees, may not be the right way. You are spending per patient per month around more than 1 lakh. And I will just leave apart these short-term complications. So not only the quality of life deteriorates, even it is heavy to the Indian patient. Next. So I'll skip this. Next, please. What next? If I do not, and I'm still adamant on some form of treatment, I think radiotherapy is a good option. Next. A concurrent chemoradiotherapy or radiotherapy post-CR could be option, and we have data set from Italy to tell you that the survival can be as high as 75 to 80%. Next. Next. So I'll skip this slide. Next. Next. This is here. Look at the right. Go back, please. Look at the right graph. Even after a patient has T0, N0, M0, And look at the right graph, even the graph is still falling after cystectomy. The survivals are still falling. So you have deaths even after and relapses even after 5 years. The point is that not that you do cystectomy and the cure for life. So why not observe and then do a cystectomy when they relapse locally? Next. So to conclude, level 1 evidence is definitely lacking. There could be issues which my opponent rightly showed, that a clinical CR may not correlate with a pathological CR in anyways, but most of the trials did do a TURBT to document that. But there is been literature in the past decade demonstrating comparable survivals. Next. And not to forget the cost and complication associated with cystectomy. Next, my last slide. Okay, I now do see Dr. Srivastav telling me that yes, we can avoid cystectomy in the future. I hope that's the take-home message for today's debate. Thank you.
So he did it already. So with this, I'll ask Dr. Ashish Kamath to conclude the remarks on this debate and to understand which way the wind is blowing towards.
Yeah, so again, congratulations to both the debaters on presenting a very nuanced and balanced side to this question. And again, congratulations to the organizers in selecting this very important topic, because this is a topic is on every annual meeting. In fact, the FDA had a workshop on it a year and a half ago, and coming in August with the International Bladder Cancer group that I lead and many of you are part of, we're having this as one of our featured sessions to come up with actual guidelines for recommendation on what to do. The short answer is yes, radical cystectomy is a cure for patients even after they have a clinical CR, but also especially when they have a PAT CR. And that's one of the reasons, for example, the FDA does not allow you to use a P0 status to result in drug approval, because just because a patient has P0 doesn't mean they actually will derive long-term benefit. But that is also a reminder that just because a patient has a clinical CR after neoadjuvant chemotherapy, he or she definitely does not then portend to have a better long-term survival. So to answer that question, there are many prospective randomized studies currently ongoing that use molecular markers. One of them is the DDR, which is the DNA damage repair genes. As you all know, patients that lack those genes have a decreased ability to repair the cancer cells after chemotherapy. And there's a thought process that those patients might actually be better served if they have a clinical CR without doing a radical cystectomy. So that's a trial where those patients get randomized. There's other genes, et cetera, that are being looked at. The bottom line today, there is no reliable predictor of being able to predict who amongst those that has a CR can actually be then translated to long-term survival. So currently, if a patient has a clinical CR, he or she should be offered local consolidation. Now, radical cystectomy is still the preferred local consolidation, but radiation in the appropriate patient is a reasonable option. So it's not that you have to rush in to take the bladder out. But without local consolidation, the effects of chemotherapy or immunotherapy are short-lived. Usually these patients will recur anywhere from 3 to 9 months. And if they recur, then they can quickly become progressive and metastatic, and that's when you lose the window of opportunity. So the current standard outside of clinical studies is to proceed with local consolidation. And amongst local consolidation, the most effective therapy still is radical cystectomy.
So just a quick question. Suppose if we say another 10 years down the line, we start skipping the cystectomy or local therapy just for hypothetical scenario, and the patient recurs, would the same systemic therapy be equally effective at that point of time when we reuse it? Or there would be a chance?
No, it depends upon the time point. Ideally, if a patient has a recurrence that's late, and by late, it's an arbitrary time point, but we use 18 to 24 months, then yes, the thought process there is that it's a new tumor. And then yes, the same systemic therapy can be used in that patient. It's the same paradigm we use for intravesical therapy. If it's a rapid recurrence within 6 to 12 months for sure, then the thought process is there was a resistant clone that you're now detecting. And if it's a resistant clone, you would not throw the same drug on the patient.
Right. Thank you so much, sir. So we'll move on to the next topics. Doctor, I made Dr. Sahu's life actually easier by putting complications of cystectomy as the next topic after his talk. So it's a privilege to invite Dr. Anup Kumar, a professor and head department of urology, Safdarjung Hospital, for giving us insights on intraoperative and perioperative complications of cystectomy and conduit. So please start sharing the screen, sir.
Good evening, everyone.
Yes,
I think I'm audible.
Yes, sir. It's seen and screen. If you can make it full screen. Thank you, sir.
So thank you very much, ISU USI, Dr. Ashwin, for inviting me to this wonderful webinar. And I was given the task of showing some complications. I went through my whole case selections. I could not find much of the complication, but still, I'm presenting one which is, I think, quite important for the youngsters who are watching this. So this was a patient, 62-year-old male, and he presented with gross painless hematuria for last 6 months. And on evaluation, was found to have muscle invasive CA bladder. And we can look at the imaging. So it was a big tumor mass involving the both almost the ureteric orifices and the upper tract, the left side hydroureter forces were there. So metastatic workup was normal, and he was taken up for robotic radical cystectomy with extended pelvic lymph node dissection and intracorporeal conduit. And this was the final histopathology: high-grade TCC, PT2, and all the lymph nodes, they were negative, and the margins were negative. So this patient was kept under follow-up. Everything was going fine, and as per our protocol, the stents were removed. And after 2 weeks, and the patient was coming the follow-up, and at 3 months, CT scan was done, which showed collection. You can see on the left side, the pelvic region of around 6 by 5 centimeter, and the upper tract was normal, and rest of the thing was normal. So this is something I think which is quite common if once you done extended pelvic lymph node dissections. So if you find such kind of collection, patient is totally asymptomatic right now. These are some of the differential diagnoses of such kind of collections. This can be local recurrence when it is thick-walled and enhancing wall. This can be urinoma if there is a contrast excavation inside the cavity. This can be a lymphocele, thin-walled and clear contents, and can be hematoma with infected collection. These are some of the DDs which comes to your mind when you see this kind of collection. And in this case, it was lymphocele. And we have seen if we do extended pelvic lymph node dissection, 27 to 60% patients, they do develop lymphocele, but only 2 to 10% patients, they develop symptomatic disease. And number of patients which require intervention is much more if you are going for extended pelvic lymph node dissection as compared to standard pelvic lymph node dissection. And nowadays, because it has become a more or less standard to do extended pelvic lymph node dissection in radical cystectomy, so therefore, more and more patients will come up with asymptomatic and also symptomatic lymphocele. So this table highlights these are the patients underwent limited and extended pelvic lymph node dissections, and again, how many patients require drainage, 30 days and 90 days. So this particular patient, it was a left side pelvic lymphocele, and patient was asymptomatic. Therefore, patient was kept under observation for spontaneous resolution, which is normally the case in these patients. However, patient presented after 6 weeks with a pain in the lower abdomen and edema on the left leg. And when a repeat ultrasound was performed, this time the lymphocele has increased to 12 by 11 centimeter, and it is now filling the entire pelvis, and the Doppler left leg was normal. So the lymphocele has increased in size over the last 6 weeks or so, and patient becomes symptomatic. So now, once a lymphocele becomes symptomatic, these are the treatment options as published in this system. One can do aspiration or percutaneous drainage. One can also put some sclerosing agent along with the percutaneous drainage. Lymphatic embolization has been described, but seldom anyone is using it. And of course, surgical marsupialization is the last resort, which we have to use if all the other options have failed. And this systematic review also shows how many patients actually you do this intervention, how many they are successful. And you can see there, percutaneous drainage with sclerotherapy or without sclerotherapy, and embolization also they have used. So in this particular patient, we first aspirated the lymphocele, and it was 500 ml of straw-colored fluid which was removed. And we did the repeat ultrasound at 2 weeks. It showed recurrence of lymphocele, and which is normally the case. If you do just the aspiration, majority of them, they will recur. And also the patient was still symptomatic. Now, in this particular patient, we did not put a drain just to avoid any infectious complication. You can put a percutaneous drain inside, but there is a risk of getting it infected. And therefore, we finally decided to go for laparoscopic muscularization of this particular big lymphocele. And intraoperatively, the lymphocele was identified and part of the wall was excised. And once this was done, now it is almost 6 weeks post-op ultrasound showing complete resolution of lymphocele. So this is a very short case showing that more and more patients in which we do extended pelvic lymph node dissections in cystectomies, we can encounter lymphoceles, but as I said, majority of them will be asymptomatic. They will not require intervention. Less than 10% will require intervention. And out of the intervention also, the surgical intervention will be less than 2%. So, so this is, I think, something which I wanted to present. Thank you very much. Any comments from the expert? I will be happy to answer.
Thank you, sir. Sir, Ashish, sir, do you want to complete or give some overview on the complications about this particular case or any other case on the conduit part, and then we'll move on to Neobladder part with Dr. Rahul, sir?
Sure. Yeah, the main comment I want to make is, again, the options were presented really well. The one thing is that we just presented last week at ASCO the results of the prospective randomized study that showed that extended lymph node dissection really does not add anything at all to patients with bladder cancer. So the standard of care should now be a standard lymph node dissection, which is where the ureters cross the common iliacs or right where the common iliacs actually bifurcate. Going up above does not seem to help. And again, myself and many experts for many, many years thought that more was better, but it seems that more is worse because your incidence of complications and deaths after radical cystectomy is twice as high if you do an extended lymph node dissection. So hopefully the incidence of lymphoceles, etc., will go down as people recognize you don't need to do an extended lymph node dissection. If you do have a lymphocele, one of the things is to pick it up early. When you let it get larger to about 500 cc's of fluid, then that's when just the drainage is not effective and you need the laparoscopic muscularization and other things. If it's picked up early, either with ultrasound or scanning, and you put a drain in, and just aspiration tends to fail, as you showed, more than 70% of the time. So if it's large enough that you need to put a drain it, then leave a drain in. And if you leave a drain in, usually in about 3-4 days, and we do this here as outpatient. Of course, it's culturally different. You may need to do it as inpatient in India, but we do it as an outpatient. Patient goes home, they call us in about 7 days as they're monitoring their drain output. They come back to the office and we pull out of the office. But leaving a drain in is the best way to get rid of this early rather than requiring surgical intervention.
Thank you so much, sir. So with this, we'll move on to the next topic with Dr. Rahul, sir. So, it's a privilege to invite Dr. Rahul, sir. Sir is a director, medical director, Rajiv Gandhi Cancer Institute, and a father figure for uro-oncology for all of us in India. So sir is going to cover the topic of complications on neobladder. Over to you, sir. I can see your screen, sir.
Okay. Thank you, Ashwin, and my regards to Dr. Madhav Kamath. He has been father of urology in this country. And hello to Ashish. I don't know, I have to put this. Okay, I got this on slideshow. So my topic is interested. Everybody is doing these diversions, and I am using it for a long time, since 1996. And hopefully I will be able to tell you a few things which we have done in this place. Can you see my slides and can you hear me, Ashwin?
Yes, sir. Absolutely clear, sir.
And it is okay because on my this thing is something is coming.
The screen is
okay with,
not moving. We are stuck at
okay,
the first
no,
slide of complications.
Okay, now this is in Keynote, and that's the problem with Keynote. I'm not very good in. I'll just yeah now. Is it moving? No.
No, sir.
That's bad. I told.
So do you want to send that as an email in the common email which I've shooted? I can
My
go
actually
on.
cursor is not visible on my this thing, so that is why
Maybe
probably
just
I'm
share
not.
that on email quickly so that we can open it at our end.
Okay, I think. Okay, can you unshare my slide? Can you stop sharing?
Yeah. So with your permission, in that case, can I go to the state-of-art lecture and then come back to you for the complications?
Yeah,
if that is okay.
Sure. No
Sure.
problem. No problem. We'll take the time. Just unshare this.
Yeah, Kiranji, can you just
fine.
get in touch with my, sir for the email and get the presentation ready if possible?
No, Navneet Arora I have.
Yeah. If you can send an email to him, we will get it done, sir.
I'll do that.
Thank you, sir. So with this, it's a proud privilege to invite our keynote speaker and key opinion leader for the bladder cancer, Professor Dr. Ashish Kamath, sir. Any introduction is going to be a short introduction for him. I'll try and be precise. Sir is a president, International Bladder Cancer Group, professor of urological oncology, Wayne D. Diddleston Professor of Cancer Research, Director of Bladder Cancer Research, the UK MD Anderson Cancer Center, Department of Urology. Sir is going to talk on non-muscle invasive bladder cancer risk stratification. Where are we in 2023? Over to you, sir. You can see your screen, sir.
Great. Thank you. Thank you again for this invitation. It's great to see so many familiar faces, friends, colleagues, albeit via Zoom, and hopefully I'll be able to see you meet many of you in India. Of course, I met you overseas, but in India in person soon. When you asked me to talk about the nuances of non-muscle invasive bladder cancer risk stratification, is again compliments to you on selecting a very good topic, because this is something that is, as was mentioned earlier, very, very important in reducing cost, not just financial cost, but also burden of care for our patients. Because when it comes to bladder cancer, non-muscle invasive bladder cancer is something that even bladder cancer experts that we train are not very familiar with as far as recognizing the nuances are concerned. And again, we all know the risk classification of bladder cancer. This is the AUA risk classification, which was published, again, now 2016, updated in 2020, and hasn't been updated yet. But if you look at the high risk classification, it's T1 high grade TA, large high grade TAs, and any CIS are considered high risk. If you have a smaller high-grade tumor, it's considered intermediate risk. Now, we all know when we're doing a TURBT, one day a tumor looks like it's 2.9 centimeters, the next day it looks like it's 3.1 centimeters. So having this 3 centimeter cutoff is very arbitrary, and most experts don't follow this, but this is what's in the guidelines, unfortunately. Now, the EAU was a lot smarter until the year 2020. And I say that, a little bit in jest because I'm part of that guideline committee too. But until the year 2020, we said any high-grade tumor, whether it's T1, TA, whatever the size is a high-risk tumor. Now, in 2021, because of a lot of push from different factions, they incorporated multiple different variables, grade 1, 2, 3, age of the patient, and size of the tumor to determine whether these patients are intermediate risk, high risk, or very high risk. And clearly, again, that size makes it very difficult for people to sort of follow, because the same patient may be high grade for me or high risk for me, and for somebody else that looks in the bladder and thinks it's a 2.7 centimeter tumor and not 3 centimeter, it may be intermediate risk, and then the treatment is very different. Now, our group here, and Kelly Bree, when she was a fellow, she's faculty now, looked at this, and we actually showed, and this was published, that if you have a patient and the patient is classified as intermediate risk or high risk, it does not matter the risk classification, so long as they have high-grade tumors. And if they have high-grade tumors, they behave very similarly, not just when it comes to recurrence and progression, but also response to BCG. Progression to any stage, and of course, progression to muscle invasive or metastatic bladder cancer. And if you look at the molecular makeup of these patients, high-grade tumors, no matter if they're CIS, TA, or T1, they all behave very similar. So to use this artificial sort of barrier of 3 centimeters really doesn't make any sense. And that's why our group, the International Bladder Cancer Group, the SITC group, which is the Society of Immunotherapy for Cancer, the FDA and others say that it doesn't matter what the size of the tumor is. If it's a high-grade tumor, consider it high risk. If it's a low-grade tumor and it's small, and again, here you could use size if you want to, then you can consider it low risk. And if it's any low-grade tumor, that's not a low-risk tumor. So if it's a tumor that's not solitary, not primary, and it's relatively large size or multiple, consider those tumors to be intermediate risk category. And that's a simplified definition that most experts use when they're designing clinical studies, when they're taking care of patients, and when they're deciding on treatment algorithms for these patients. So with that in mind, if you have a low-grade tumor, that's a first-time small solitary tumor, the AUA algorithm is resect this tumor, use postoperative chemotherapy, and then monitor these patients. The monitoring is done at 3 months, then 9 months, and then once a year. And that's really more than adequate for these patients with low-risk tumors. If the patient has an intermediate risk cancer, then the recommendation is to obviously make sure you have a complete resection and then consider either chemotherapy or BCG. And how do we make this decision between chemotherapy or BCG? There's multiple studies that have sort of looked at this in the past. But the bottom line is that we should recognize that a patient that has low-grade multifocal recurrent tumors now still is on a spectrum of disease. If you have a first-time large low-grade tumor, that patient has a much lower risk of recurrence and progression than a patient that has a large low-grade tumor, TA, recurrent, multifocal, et cetera, et cetera. And it's also important to recognize that this group of patients, the intermediate risk non-muscle invasive bladder cancer patients, is the largest group of patients that we will see in our practice. And, we oftentimes focus on radical cystectomy, chemotherapy, radiation. That's only 20% of the patient population. 80% have non-muscle invasive bladder cancer. And within that 80%, roughly 60% are this category. And a lot of people just sort of gloss over it and don't pay much attention. But it's very important to recognize that this is the largest subgroup of patients that we take care of. And that's why it's important to sort of define this spectrum. So back in 2014, the International Bladder Cancer Group proposed a classification system for these patients with intermediate risk bladder cancer. And then this was updated last year by one of my fellows who many of you might recognize because he was in the UK for many years and has published multiple clinical studies and has come to spend some time with us here in the US. And this article was the most commonly downloaded and cited article in Europe and Urology last year. What we have proposed, the International Bladder Cancer Group, is that this intermediate risk tumors is such a broad spectrum of patients with multiple different risk classifications and risk parameters. So if a patient has a larger tumor, and we use 3 centimeters because that's what's commonly used, but if it's large, it's the more important thing. If it's multiple, early recurrences, frequent recurrences, or if they've failed previous intravesical treatment, that's what we use to determine their risk scoring. If they have none of these risk factors and they just fall in the intermediate risk category, they have a very, very low risk of progression. That's the important thing to keep in mind. If they have 1 to 2 risk factors, their risk of progression is about 11%. And it's amazing because we normally don't think of low-grade tumors being progressive, but these low-grade tumors can progress. And of course, if they have multiple risk factors, 3 or more, they can progress in as many as 17% of patients, which is more important than the recurrence rates. And because of that, if they have 0 risk factors, we recommend you treat them as a low-risk patient, just a resection, perioperative chemotherapy, and monitor. If they have 1 to 2 risk factors, consider chemotherapy over BCG because the side effects from chemotherapy are lower. But if they have 3 or more risk factors, even though they are considered intermediate risk and have low-grade disease, consider BCG in these patients and try to get at least 1 year of maintenance therapy because that really helps reduce the progression risk for these patients. A little example with a case, a classic, 66-year-old male, gross hematuria, heavy smoker, has quit for the last 8 years. Imaging was performed, everything was negative. You look at the bladder, cytology is negative with low-grade tumors, as we all know. And you see this tumor here in the bladder appears to be low-grade TA. Now, most of us know if you're in expert hands, expert urologists are able to predict grade of the tumor at least 70% of the time just looking at it visually. Stage is harder. It's harder to know whether it's TA, T1, et cetera, but if it looks low grade, it's likely to be TA, a tumor. And in that case, obviously, you resect this tumor, and you know that this tumor is likely to be low grade. So the options are really single dose of chemotherapy because this is low grade, single dose of immunotherapy because the patient is a smoker and that is a higher risk of recurrence, or because this patient is going to need additional therapy, just defer it till pathology is back. And the right answer here is to do a single dose of chemotherapy because you will be correct more than 70% of the time if you assess this tumor and it looks like it's a low-grade tumor, TA tumor to you, and that single dose of chemotherapy is all this patient will need. You won't need to do anything else. You definitely don't want to do BCG because putting BCG in the bladder immediately after resection can cause sepsis, and this patient's not likely to need additional therapy. And that's the message there. Now, just to follow this patient, because that was a low-grade, low-risk patient, this patient is followed ultimately at 12 months, has multiple tumors, which also appear low-grade. So now this patient essentially classifies into the group of being an intermediate-risk bladder cancer patient. Cytology, of course, is negative, as you would expect in a patient with a low-grade tumor. And these are the tumors as you see them here. This is intermediate-risk patient, and this patient has now gone from the low-risk category to the intermediate risk category of patients. And if we put these patients' parameters in a calculator that the EAU provides, it then spits out the result that most of us know, right? We don't need to go to an online calculator. We don't need to waste time putting in all these parameters. You now know that if a patient is low grade, has recurrences, this patient is an intermediate risk patient. You don't need to really look at any calculators. And now you know that this patient would benefit from adequate adjuvant therapy. Intravesical chemotherapy is recommended for patients with fewer risk factors because it's a more benign treatment and more easily tolerated. For patients that have more risk factors, we do recommend immunotherapy with BCG for these patients. So again, if you look at the same patient, the patient underwent TURBT, induction gemcitabine for 6 weeks, and then we recommend monthly maintenance therapy. This patient, again, after a year, had recurrent tumors. Now, when you have recurrent tumors, even if they're low grade, you want to make sure that the upper tract is negative. So you do a CT urogram, this was negative, pathology was TA low grade, and this is what the tumors look like when you look at it with blue light. And this is something that's important to get rid of any sort of CIS that might be visible. Now, because this patient has failed prior therapy, it has multiple risk factors, this patient goes on to be a high-risk patient. And then this patient essentially is considered for BCG therapy, which is what was recommended to this patient and what is present in the guideline recommendations. Now, moving on to the high-risk category of patients. For these patients, as we discussed earlier, if they're T1, or if you think you did not do an adequate resection, even if they're TA, a repeat resection is recommended. If they have variant histology, lymphovascular invasion, if they're deep T1B, et cetera, consider a radical cystectomy. But BCG is still a very valid option for these patients. And many of us remember data from many, many years ago that suggests that BCG doesn't work well for T1 high-grade patients or that BCG doesn't work well for high-risk patients. If you look at the current data, and this is just an example from our series that Justin Madeley, when he was here, now he's an associate professor in Florida, looked at, we showed that in patients in the current contemporary era, if they're intermediate risk, their progression-free survival is 100%, right? They don't progress. And even if they're high risk, their progression is in single digits. It's not the 60% progression that a lot of the older series, especially from Memorial, seems to suggest. These patients actually do really well. And at 5 years, even in the high-risk category, their progression-free survival is better than 90%. So 90% of patients at 5 years will not have progressed despite having high-risk bladder cancer if you give them BCG adequately. And again, it's important to recognize that the EAU puts out in their risk calculator the risk progression for patients treated with high-risk disease, and it shoots out a very high risk of progression. That's wrong because this calculator is based on patients who do not get BCG. And if you actually look at the predicted progression rate for patients with very high-risk disease, it's 40% in the EIU calculator. When you look at adequate BCG, it's only 14.8%. So yes, 14.8% is not nothing. We do have to counsel our patients and follow them closely, but it's clearly not 40%. And that's why it's worth giving these patients with high risk, where the progression is 5.8%, or even very high risk, where the progression is only 14.8%, not 40%, a chance to save their bladder with intravesical BCG. Now, of course, BCG doesn't work for everybody, and that's why we put forward the definition and endpoints when it comes to BCG unresponsive bladder cancer. And as many of you know, that has been adopted by the FDA and allowed an explosion of drugs to be approved that have followed this paradigm. And if you look at this paradigm, what is BCG unresponsive disease? Now, remember, this definition was something we created to allow investigators and pharmaceutical companies to perform clinical studies. So it's high-grade T1 disease at 3 months, or Ta-T1 disease that has responded and then recurs within 6 months, or CIS that recurs within 12 months of the last exposure to BCG. That's the only group of patients that's allowed to go on single-arm studies. Everybody else that has had BCG and then has recurrences, if you look at the papers, make sure that the papers have a control arm, because otherwise the results are not very easy to discern, because the results with BCG are so good, as I mentioned earlier. In closing, I do want to make a reminder to this group. You know, we see pembrolizumab, we see gene therapy, all of that coming into the forefront, and the medical oncologists, especially in the US, are trying to take away the care of patients with non-muscle invasive bladder cancer. We have to remember that the urologist is the one that drives the care of these patients. And it's very, very important that we as a field continue to take care of these patients despite the advent of systemic therapy for non-muscle invasive disease. The other thing that I want to compliment many of you that were part of this global survey that we just presented at ASCO, actually, from 45 countries, including India, is the patient responses and what do they want. What they want is very important, and sometimes it's very different from what we understand of bladder cancer. And with that, I want to thank you for the invitation and thank you for your attention, and I'm happy to take any questions if you have time.
Thank you so much, sir. That's an insightful talk. I think for the want of time, we'll take Dr. Rawal's talk first and then address all the questions, if that is okay with you, sir.
Sure, of course.
Yes, sir. So, Rawal, sir, should we start with the presentation? Yeah, I think someone has already started. Yeah. So, sir is going to talk on complications of neobladder.
Yeah, can you hear me now?
Yes, sir.
Okay, and you can see my slides.
Yes, sir.
Yeah, so just to say that complication about neobladder, I have attended like last 27 years. I am in field of uro-oncology and I have seen all the leading urologists, uro-oncologists rather, who is doing neobladder, especially Studer. He will say that this is one surgery where, you know, one thing goes wrong, so it leads to, you know, everything is the cascade reaction or events. So you have to be very careful when you do this surgery. But having said that, what my friend Dr. Sahu has said in the debate with Srivastava, that the complication of cystectomy alone is 60%, but he did not subdivide it into the CDC 1 and 2 and CDC 3 and 4. And if you see the complication of chemotherapy, they are much, much more than the cystectomy, which I see every day in this hospital. What happens is that radiation or medical oncologist, when the complication occurs, the patient comes to surgeon. It never goes back to the radiation or medical oncologist. And about looking at the radical robotic and the open approach, there has been 3 trials which I'll be mentioning in this talk, that there is no difference between the doing radical cystectomy by open approach or the robotic approach. This has been from Deepan Parekh. And if you go for robot assisted and open versus radical cystectomy with intracorporeal diversion, there is no difference in the complication except the perioperative. During operation, the blood loss is more in the open surgery. And this is with the same with intracorporeal versus extracorporeal urinary diversion followed by robot assisted radical cystectomy, which is known that only the difference is in the blood transfusion. not in any other complications. Complication of neobladder, pertaining to neobladder, I'm not talking about the pertaining to cystectomy or pertaining to the diversion. Like it can occur because chemical that metabolic complication occur with diversion, any diversion, but with the cystectomy, mainly are like these two. One is ureteroileal anastomosis, which can be urinary leak, or ureteroenteric anastomotic stricture, or neobladder reservoir can be urinary leak or fistula or UTI, or there can be metabolic complication, which I will be just enumerating. And there can be incontinence, which I'll be talking in detail, and there is a retention or incomplete evacuation, or maybe reservoir renal calculi, renal function deterioration in UTI. These things will be enumerating. We'll be focusing on the leak and the retention and reservation and the incontinence and urinary leak. These are the complication rate after cystectomy with urinary diversion. You can say that 2/3 of the patient will have in first 90 days the complication, but that doesn't mean they will be actually having major complication. The majority are minor CDC 1, 2, and 20% will experience, only 20% will experience the major CDC 3 and 4. Mortality rate is in the all over the series. We have seen that in 30 days, mortality rate is 2.1 to 3.2%, and 90 days 3.2 to 8%. Now, if you go further, 1 in 4 patients, like 25%, will be readmitted within 30 days. But this can be reduced by many measures when you are taken, when you have a high volume center where you can give the patient antibiotic for long-term antibiotic. Then they probably will not come because of the infection, but they may come with the failure to thrive. This can be reduced infection, but they can work with the failure to thrive. They can have urinary problem, they can have GI problem, which can occur in these patients. And 95 of these patients who come back to the hospital, they will have 1 or 2 of these things. Now, the surgical complication which can occur is, like when I will share this patient who has had who is a 70-year-old man who has had cystectomy and neobladder, in the readmitted with fever and CT scan showed a large fluid of collection near the reservoir, which fills the contrast on delayed image. This means it's obvious that it is from the reservoir. Leak is from somewhere else, somewhere from the reservoir, or maybe ureteroileal or whatever it is. Then he had ureteric stent and he had catheter. So the next step was to put a percutaneous nephrostomy pigtail catheter in this, and then see what is happening in this patient. Now, where from the leak can occur is that can be from the neourethra. This is a technique which we make in our center. We have afferent lobe, the reservoir, and the neourethra, and the leak can occur from these places. Like this one is ureteroenteric anastomosis, or it can occur from the end of the chimney, which we staple always, which can be avoided with the stapler, or it can occur from the neobladder itself, or it can be at the neobladder urethral anastomosis. And what are the symptoms in these patients? They have incidence of 3.9% and 3 to 9%. They can have high drain output, which you can prove that it is urine by drain through create, abdominal distension, ileus, and chemical peritonitis, and by the drain through create, and if there is a fever due to the collection. Just going back on to this, that to diagnose it from delayed phase, you can see the site of leak. You may need a cystography, or you may do the ureterogram also. It's the site of collection, and position of drain is very important in these patients. Sometimes the drain, most of the time, the drain hits as the pouch which you make with the urethra, and there's where the drain is impinging, and the urinary leak occurs in that. And the treatment is IV antibiotics and supportive care, maximal urinary drainage with the bifocal catheter or splint. In case of collection, put the pigtail drainage, and wider. Sometimes, very rarely, they will require the PCN if there is a leak from chimney. It is very rare. The prevention can be done by leak test before reservoir, post-op gentle bladder wash to avoid the mucosal mucus. Actually, it can block the catheter and can lead to the the leak. And the ureteroenteric anastomosis, one has to do watertight, but you should not be pushing it too much pressure on the anastomosis. Just to be just approximation of the ureter and the intestine where you have made the ureter, the hole for the joining the ureter. Avoid excessive mobilization of the ureter. Avoid direct handling of the ureter with the forceps, and always use the splint or stent. This one small video you can see most of the time in this double when you do the double flap, you actually fold the reservoir. There is a place where it can occur, this leak can occur, which you may have to buttress with the single stitch. This is another scenario where a 68-year-old man has had fever, chills, and left flank pain. And 2 years previously, he underwent radical cystectomy, ileal conduit diversion in T3B, transitional cell bladder cancer. Abdominal CT scan reveals the left hydronephrosis. This can occur with the Neobladder also. So I just took this case, a normal right kidney with a retroperitoneal mass surrounding the left ureter. And in this patient, next will be either you do the nephrostomy, which is actually the correct thing, and then you evaluate this patient for where the stricture is, whether it is because of the recurrence or whether it is because of is it just a healing problem. The incidence can be 4 to 9%. Risk is lifelong. Risk factors are anti-reflux, it is 30%, 13%, and the refluxing is only 3% when you do the ureteric enteric anastomosis, or when refluxing anastomosis, there is a 3%. The aggressive ureteric mobilization should be avoided. Left ureter is more common, and there is no difference between the open or lap or robotic technique. Slit shape versus ileostomy or shield ileostomy. You all know that Bricker's technique has more incidence of ureteroenteric anastomosis stricture. But if you do the Nesbitt's technique, where you remove the part of the intestine also, which is done in our center also, then that incidence is very low. Common site is ureteroenteric anastomosis left more than right, and in the left ureter where it crosses over the aorta and beneath the IMA. Nature, most of the time it is benign in 85% and malignant in 15%. Now, these are the management. Not all hydronephrosis are pathological. Following urinary diversion, you must do the renogram. Just see whether it is refluxing or it is just obstruction. Just not hurry for seeing that it is just obstruction. One can do the routine leukogram. We do not do this in what is described. Patient can have flank pain, fever, pyelonephritis, deterioration in the renal function, progressive hydronephrosis, and this actually can be lead to the diagnosis whether it is obstructive or it is because of the reflux. One can do the renogram and see what is the real obstruction. Is it real obstruction? What is the function? You can take a decision of this helps in making a decision. Then contrast CT and urography. MRI also helps you in ruling out a stone disease, evidence of a stricture where it is, whether it is benign or malignant, and length of the stricture, which is very important, and the status of the kidney. Nephrostogram, if you have a nephrostomy, that will differently delete you give you the exact anatomy where the stricture is. These are some pictures where you can see the long stricture here, and this is our patient who actually has had a MRI was done to rule out recurrence, and this patient had a small recurrence at the ureteroiliac anastomosis. You can see here, ureteroenteric anastomosis. This is an nephrostogram. They may have to do in some cases where you can see where the stricture is, and you can plan your treatment in these patients. Now, what are the treatment? You have to assess the length and renal function. A stricture is less than 2 centimeters, and renal function is more than 20% of the function. If it is right, you can try doing endoscoping incision. Personally, I have not done. Maybe Ashish can enlighten on you. On the left side, consider formal repair, because the left side probably endoscopic incision will not help. If a stricture is more than 2 centimeters and the moiety is functioning more than 20%, consider formal repair. If the moiety is less than 20%, it is better to do nephrectomy, or you can observe. And These are the, some pictures from the literature where you can use helium YAG laser or balloon dilatation through the antegrade approach. They can help in patient, especially if the patient is elderly and he's not fit for surgery. They are definitely helpful, but they are hardly used at our center. The prevention of ureteroenteric anastomosis is watertight, but you should not tighten the suture too much when we are doing the anastomosis. You have to take just the ureteral wall. Do not take the periureteric sheath. Avoid excessive mobilization of the ureter and cut the ureter as proximal as possible. As many of you would have seen a student doing, we follow that. Avoid direct handling of the ureters and with the forceps. Robotic, you can use ICG, which is now very common in all over the world, and it's picking up everywhere in India. Also, you can see here in this patient, you can see this is not the segment which is getting vascularized, so you better cut here. Now, this is another scenario where 53-year-old woman had anti-extentation and neobladder with optimal omental flap interpositioning 3 months previously. She still has total incontinence day and night. And next step is what is to be done: reassurance or reinforced Kegel exercise, refer for physical therapy for pelvic floor strengthening, or evaluate for possible of VVF, which can occur in these patients. Prescribed extended release oxybutynin or fluorodynamics. I will probably evaluate for possible VVF. As you see that in pouch vaginal fistula in female after neobladder, the incidence is 5 to 10%. Risk factor is anterovaginal wall excise. Post-radiation patient, if you have excise and anterovaginal wall, then definitely. In younger patient, when you are doing genital sparing surgery, it may not happen. Prevention is watertight closure of the vaginal stump and omental interpositioning when you're doing the urethro pouch anastomosis. Presentation can be the leak of the fluid from the vagina in post-operative period. To urine out, you have to rule out the urinary leak by doing the cystogram, and then persistent significant urinary incontinence in this patient. We must suspect there is some leak from the anastomosis. The evaluation can be done with the pelvic examination. Instill methylene blue dye in the bladder. You can see it coming through out vagina, and the treatment is conservative. Either do the catheter placement or the bilateral PCN, or you can do the surgical repair, or one can convert it to the ileal conduit. Now, the mechanical complication which can occur in these patients is continence. This is the one problem. Daytime continence, actually, it improves gradually into 6 to 12 months. It is achieved in 80 to 90% of the patients. So daytime continence in neobladder is not a problem. But problem is the nighttime continence. And the risk factor for daytime continence is age, older than 65 years, poor external urinary sphincter activity, detrusor. I'll not say detrusor overactivity. It's actually there is no detrusor in the neobladder. I'll come to the urodynamic studies in the next few slides. Colonic segment definitely have high pressure. They may have incontinence, lack of nerve sparing, diabetes, and if the patient has had hysterectomy, they can have the problem. The nighttime continence is not very good in these patients, especially it takes long time to recover, 12 to 24 months. Persistent nocturnal incontinence can be there in 20 to 50% of the patients. And physiology, you all know, because of the absence of neurological feedback and decreased nocturnal sphincter tone in the night, the bowel secretes water, and the physiology, the nocturnal diuresis with age. This is why this patient starts having nocturnal incontinence. The evaluation, it should be delayed. You should not hurry for evaluating incontinence. You should wait at least 12 to 18 months. And the physical therapy is with the biofeedback is the treatment. Urodynamic study is controversial because it's not a detrusor muscle. Many times when I discuss these things with a student, I say that your urodynamic study should not be done in these patients. We can have comments on this from Ashish, but then they do advocate that assess the maximal urethral closure pressure. We actually have not done this in our patient. They have even suggested that urethral debulking agents, puvovaginal silk, and artificial sphincter placement in these patients may help when they have the troublesome incontinence, which in our patient have not been required so far in last 27 years. Rather, I will say I will be honest, because I have started doing Neobladder after 2005 only, or maybe 2004. These are algorithms of the patients who have either urinary incontinence, they have fistula. Yes, then you can treat with them if they have urinary incontinence. I just not go in detail. I just stick to that these patients may require, when they have sometime the overflow incontinence, they will require clean intermittent catheterization, or rarely they will require the undivergent to ileal conduit. That actually may be in few patients you may require, and we actually had to do in few patients when they have troublesome problem in the long term. So other problem is hypercontinence, and this is mainly problem in the woman, not in the men. In men, you can sort out with the ICC, but in women, this is very common, and can occur because of the current UTI. You have to roll out UTI, new onset of overflow incontinence. One thing which I'll say, that when you are doing Neobladder, must make the urine is sterile. If the urine is not sterile, patient will have a lot of problem with the voiding. So this always emphasize that urine culture should be negative when you do these patients. On the follow-up, you must do the urine culture. And the patient, if he has hypercontinence, you should evaluate with the bladder if it is palpable, high residual urine, or new onset of hydronephrosis. Pathophysiology is mainly a stricture which can occur in male, or mucosal fold, which we reported in 2005 or 2006, which may require the fold resection. We do it in many patients, and this actually helps the patient. The reason is the urethral tube which we make, actually even a small approximation coaptation of mucosa can have the problem with the urinary voiding, because the bladder is low pressure. It cannot come out cannot overcome the even if there is small obstruction. So whenever you have any high residual urine or urinary problem, you must scope before teaching him CIC even. There can be malignant stricture, especially in the late follow-up of the disease, and the abdominal hernias can interfere with the urinary voiding problem. Factors in women is very well evaluated, discussed, very well showed that thinking of Neobladder as it falls in the posteriorly. This has been shown by Mansoura group also. Posterior wall prolapse from the vaginal stump can occur. Is the late retention prevented by the support of vagina, and you can put the round ligament to the angle of vagina, or if you can do the genital sparing surgery and you do the Neobladder in female, that probably is the best thing. Redundant Neobladder, especially hot men, if you say this thing to hot men, he will actually scold you. But many people criticize that more than 60 centimeter of ileum, if you take, then it can become the redundant Neobladder. This is our case, who has had the mucosal prolapse, and you can see how this is obstructing the main bladder. And if you resect it, these patients, they void. We have seen in Patel, we have reported also. I'm not going to talk in detail about metabolic complication. I don't think there is much time, but I'll just enumerate. They can occur with any diversion, like electrolyte imbalance, altered sensorium. If you're not covered with soda mint and you're not checking their chloride and bicarbonate, these patients can end up with the altered sensorium, especially if they have diabetes. Abnormal drug metabolism can occur to these patients. Osteomalacia and growth retardation too can occur to these patients, which has to be treated. And you have to keep in mind persistent and recurrent infection, formal formation of renal and reservoir calculi. These stones are soft stones. One thing is that, which I have learned with my experience, the reason why I am telling you that I sent one of my patients to a stone center, not realizing that you can even wash them with the Alligator forceps, or you can just crush them with your small biopsy forceps. They are soft stone, so need not to send it to even a stone clinic. You can treat them at your center if you are a dedicated uro-oncology center. Problems ensuring the removal of the portion of the gut from the intestinal tract, which can be a vitamin B12 deficiency. There can be gallbladder calculi or some other dyspeptic problem. Then the development of the urothelial or intestinal cancer can occur in these patients. if they live long. This is well documented. With that, I'll end up my presentation here, and I'll thank Ashwin and everyone to invite me here for this wonderful meeting.
Thank you for taking us through the journey of your neobladder career. I think you are the best person to talk about the complications of neobladder, considering the vast experience. So for the short want of time, Dr. Kamath has to leave for an OR. So can we quickly have a rapid fire of about 5 minutes quickly of some questions, and then we'll go to the chairpersons for the expert comments?
Sure, of course.
Kamath, sir? Yeah, so I'll just get the questions going. One of the questions was, where do we position sequential chemotherapies in the management of NMIBCs? Is it worth a salt? Sequential chemotherapies.
Yeah, no, it absolutely is. If you're considering patients that have failed after BCG, then for those patients, currently the standard of care in the US is a combination of gemcitabine and docetaxel. If there are patients who are BCG naive or in the low to intermediate risk category, then currently gemcitabine is the standard of care because it has low toxicity and is cheaper than mitomycin. But mitomycin is also a very effective treatment. It's just more expensive, so we tend not to use that.
Right. Is immediate post-operative mitomycin for a very angry-looking, high-grade looking tumor or multiple tumors or with a positive cytology? Do we consider that, or it's only for low grades?
Only for low grade. There's a lot of data to suggest that immediate postoperative chemotherapy for high grade tumors is not beneficial, especially since you will need more treatment down the road anyways.
Right. Do you use interleukin scoring for predicting response or adverse effects of BCG therapy? And are there any markers to predict response to gemdosi, intravesical chemo?
Short answer, yes, there are markers that we have developed here in my laboratory, but there are research tools. So there's no clinically validated marker currently available.
Yeah, any cutoff for percentage of micropapillary portion in the entire specimen for deciding about cystectomy? Is there any percentage cutoff, or any percent is good for cystectomy, or should be recommended cystectomy?
No. We looked at the percentages, and it seems to be about 20% is sort of the cutoff. If it's a small focus, 10%, 5%, those patients actually do well without a cystectomy.
All right. I think we've got most of the things, sir. Yeah, as someone was asking about mitomycin maintenance for intermediate risk. So if you're recommending mitomycin, we should complete the maintenance for a year or so after 6 inductions.
Yes, currently the standard of care is induction and then once a month maintenance for at least 1 year. And then after that, it's a risk stratified based on, multiple different factors, but at least 1 year is beneficial.
Thank you so much, sir. We sincerely appreciate your time out of your busy schedule. It's been almost a couple of hours or just quarter 2 hours. And you've been there since the start of the program. Chawla sir, do you want to thank sir, because sir wants to move for the OR, and then I'll get the chairpersons for the words of wisdom and conclude the sessions. Chawla sir.
Meanwhile, can I ask Ashish my question? Ashish?
Yes, sir.
Ashish, can you answer my question in chat box that do you use NACT in patient who have squamous differentiation and glandular differentiation? You avoid NACT in these people?
Yeah, no, we at MD Anderson avoid chemotherapy in those patients. The answer, again, unfortunately, on the AUA board, just to make it simple, is use chemotherapy for everybody with muscle invasive disease. But those with predominant squamous or glandular differentiation, they do well with surgery as well. So we take them straight to surgery.
Yeah, thanks.
Again, I want to compliment everybody, and Sudhir, your talk and all the talks were phenomenal. Unfortunately, I have to run, but they were really, really good. And I'm glad this is
Yeah, I know. I miss MD Anderson after Chris Wood. It's been very bad for me that Chris is not there, but hopefully we'll catch up with you soon.
Absolutely.
Thank you.
And thank you again, everybody, for the invitation.
Thank you so much, sir. Thank you so much, sir. So I would like to invite my chairpersons. They have a vast experience of bladder cancer management in their entire lifespan, and they are the best people to talk about the words of wisdom for trainees or early learners like us. So Dr. Makran Kochikar sir and Dr. Anish Srivastava after that on the topics and their perspective, whichever they would want to take as the opinion. Kochikar sir? Is Kochikar sir logged in? Sir?
Ashwin, he texted me. He got kicked off the platform and he's not able to get back on.
Oh, I'm so sorry. All right. Sure, sir. Thank you so much. And Dr. Srivastava, sir? Anish Srivastava, sir?
Yeah. Okay.
Yes, sir.
Am I audible?
Yes, sir.
Thanks. An excellent webinar. And Ashwini, all the urologists, everyone from a young urologist to the most elder one, nobody can survive without doing TURBTs.
Yes, yes, sir.
So I mean, this topic is very interesting, and there are controversies coming up because, as always, there are people who try to challenge the existing practices, and that is how the evolution and the medical practices improve. So for the second look TURBT, if we look at, there is fierce debate going on. But I think, as Ashish made it very clear at the end of his lecture, as an expert, that it must be done, right? Except in selected circumstances which are now coming up, because there are, we all know the opponent could show us only some literature. One was from PGI Chandigarh, and even in SCPGI also we were working and we were giving thesis on, because these are the high volume things where the students were given thesis and all, and we also found that the upstaging is not to the tune of, say, 20 to 49%. That all of us now are realizing, as is described in the Western literature, due to whatever reasons. But yes, it is there. Upstaging is there. And in our series also, it was about 12% when we looked at. And if you look at the latest European guidelines 2023, again, they have given, lot of sites like, this is what it is, this is what, but they have not given any definite mandate, except that it is mentioned that it can be avoided in certain selected circumstances. So I think after this talk, it is very clear that we must do it unless there is a definite evidence or more prospective randomized trials suggesting the same. Then coming over to the issue of the radical cystectomy following either IO or neoadjuvant, I think there is some debate going on when there is hardly any disease, or if you have T0 disease, so whether cystectomy should be carried on or not. I think we need to wait and till we get molecular markers wherein we can safely say that this patient may not require a cystectomy. Till that time, all muscle invasive disease should be done. Right? Then coming over to the extent of pelvic lymph node dissection. Again, standard versus extended has been debate going on for a long time. With the robotics, initially it was thought that extended is difficult, but now it's not so. And the data still suggests that extended is better. Point is that Lymphocele, whether it will be more with extended or standard, I think we cannot quantify that. So Lymphocele would be a part of it, whether you do standard or whether you do extended. Now, I have reservations with doing any kind of surgical marsupialization for a lymphocele, which is though rare, but if it forms after the pelvic surgery. Why? Unlike the renal transplant, post-renal transplant lymphoceles, where there is a constant source of production, and because they are retroperitoneal. So there we do the marsupialization, because abdominal cavity can absorb 400 to 500 amount of lymph every day, right? That's where we do surgical marsupialization. In a pelvic, following a pelvic surgery, if a lymphocele forms, it's just a kind of a, containment in an area with little thick wall and all. So aspiration should be good enough. I don't think we need to go for surgical marsupialization in that case. So two things are different. Then, of course, we had very good comments from Ashish about the NMI VC and the use of mitomycin C, which is another fiercely debated topic. And so I think in general, if you see, because this is a common topic for every practitioner, every urologist, so there are more controversies coming up at every point. And then I would, last comment, I think I would say that urodynamic studies in the these pouches, the neobladders after the radical cystectomy. So we also published our experience in 2-3 years ago in Indian Journal of Urology, but our patients were mainly the agonium pouch, the W-shaped one, and it showed very good results with good capacity, good compliance, and not much of incontinence. So I think those who are doing these continent pouches must look at the urodynamic studies and in the long run, so that we get more idea. So I think those are my comments. Thank you very much.
Thank you so much, sir. Chawla sir, are you there, sir?
Ashwin, can I ask one question? Can I ask?
Yes, sir. Raval sir or Chawla sir, anyone is around, sir.
I think Dr. Raval, Dr. Anish, or Dr. Ashish Kamal. See, one thing which we are seeing during our interpretation is the reporting by pathologists, which is T1, but they write as low grade. So I'd like to know from the expert, how do they tackle about this if it's reported as T1 low grade, whether they take it as a T1HG or they think it differently or they manage it differently. In spite of that, they beyond low grade. And second is the have we reached the stage of the consensus?
You are not very well.
So your voice is getting stuck.
Yeah. So the second question is based on the MPMRI. Do you think we have reached a stage where it's 503+, then we can skip the biopsy and all that and straight away go forward radical cystectomy? And I hope the first question was clear.
Yes, T1 low grade, whether it exists.
Yeah. So we keep on deliberating with the pathologist, but sometimes we are in a fix what to do and all that. Yeah, so these are two issues like that.
So can you go ahead with the answer, sir?
Okay. So if you are asking me again in SGPGI, we had we still are going ahead with the trial, trying to correlate the virite with done through MPMRI with the biopsy, bladder. So actually the point here in bladder tumor, it is different as compared to the prostate. So I still feel that one must go for a biopsy in a bladder. So answer could be very
just coming to the same. We do sometimes situations where we think that this may be muscle invasive. We keep on taking biopsy, and it is always reported as muscle seam, but negative of tumor, negative of tumor. So we keep on doing multiple TURBTs, but we don't reach to a definitive report of muscle invasion. So how do you encounter the situations there?
Yeah, that's what when we are not able to reach to a conclusion, even with multiple biopsies, we are talking of second lobe, this and that. How could MPMRI be, even with biopsy, if you are not able to get to a conclusion, how far will MPMRI go with us in the long? That's why I think and about the T1 low grade, I think Sudhir can give some more because this is another thing. Earlier we used to say TA high grade, whether this entity exists, but now it is very clear and established.
Yeah, I agree with you, Dr. Anish. We do not see T1 low grade, but I can say sometime pathologists can report T1 low grade when there is a extensive low grade tumor in the bladder. That time probably the patient will require cystectomy, but we do not see in our center as a T1 low grade.
Yeah,
I think many of us have not seen. It probably doesn't exist, but it does exist outside, big center, because many times pathologists will report T1 low grade. But if you see the low grade, it is either will be a small disease. And if you see the extensive low grade disease, it is T1 or TA, you have to offer a cystectomy. You just can't treat with the intravesical agent. So T1 low grade probably I'll not believe. Either it is TA low grade or it is T1 high grade.
But the TA high grade exists, as in we just discussed with
it does exist. It does exist. It's very common.
It's now actually one of the most commonly reported.
Yes,
ever since they have come to high grade versus low grade. Now the only established thing.
Because if you see some of the literature mention that T1 should be considered as something like a high grade disease only.
Absolutely.
Yeah, exactly.
Sure, sir. So, Chala sir, should we conclude the session then? Thank you so much. Thank you.
Yes, Dr. Sujata is there. I think if you can.
Madam?
Sujata, please.
Madam is there. Dr. Sujata is there.
Yeah, actually I'm there. Good evening, everyone. And thank you for all the participants and all the speakers who did an excellent job. And it was really a treat to watch and to hear everything. Thank you very much. And thank you, Ashwin, for a very well curated program. It's our pleasure to have you on our board.
Thank you. Thank you, everyone. We'll meet after a couple of months on prostate. Thank you.
Thank you, Ashwin. Thanks a lot.
Thank you, everyone. Thank you, everyone. Good night.
Thank you, everyone. Thank you.
Okay, thank you.
Thank you, Ashwin.